Hello and welcome to our latest presentation on COVID-19 and the path to immunity. The emergence of adaptive immunity in response to the novel beta coronavirus, that is the SARS-CoV-2, occurs within the first 7 to 10 days. Understanding the key features and the evolution of the B cell and the T cell mediated adaptive immunity is essential in forecasting coronavirus disease outcomes. Asserting long-term B cell and T cell immunological memory against the SARS is critical to understand the duration of this protection. So let's look at first the antibody response. There is a rapid generation of neutralizing antibody response in COVID-19 patients. There is a robust memory B cell and plasmablast expansion that can be detected early with secretion of IgM and IgA by day 5 and day 7. By day 7 to day 10, you get IgG antibodies. Now, serum IgM and IgA titers decline approximately 28 days and IgG titers peak at around 49 days, after which they start to dip. The magnitude of the anti-SARS-CoV-2 IgG and IgA titers to the spike protein correlates in the convalescent plasma with the CD4 T cell response. The magnitude of the IgG1 and IgG3 antibody to the receptor binding domain when the ELISA is done correlates well with the viral neutralization. The generation of the neutralizing antibody directed at the spike protein is the basis of multiple human vaccines now. The receptor binding domain region of the SARS-CoV-2 shows little sequence homology to the seasonal coronavirus. Although the variants in the SARS-CoV-2 spike protein may be of concern, the SARS-CoV-2 has very low variance rate, and so far such variants have not been shown to reduce the recognition of the receptor binding domain epitopes important for the antibody neutralization. So it can be taken for granted that if the patient develops antibody to the receptor binding domain, he won't have a severe infection in the future. Now coming to the cytotoxic response. In the cytotoxic response in patients who are infected with SARS-CoV-2, we find 100% CD4 cells and 70% CD8 cell response. And this response, apart from the spike protein, is to other proteins as well. Now, this response is seen in also patients who are unexposed. Almost 50% of the patients had CD4 and 20% had CD8 response to SARS-CoV-2 without exposure. This is probably because of prior exposure to other coronaviruses which cause the common cold. Now, the dominant CD4 H2 type cytokines do not appear to contribute to the acute CD4 severity. The magnitude of the antibody and the T cell response can vary and be discordant among individuals and is influenced by the disease severity. So the question remains, do we have a memory for the SARS-CoV-2 infection? A decline in the IgG neutralizing antibodies to the SARS-CoV-2 in convalescent plasma raises the apprehension of susceptibility to reinfection. Now, the antibody levels always decline after an acute phase infection in all viruses. A similar pattern is seen in the effector CD8 T cell as well. Now, the serological memory is then maintained by a small number of long-lived plasma cells that reside in the bone marrow. Rare circulating memory cells have been shown to produce highly potent neutralizing antibodies even long after the initial infection. Thus, an early decline in the neutralizing antibody level should not be of concern for reinfection. The key is what levels these antibody titers stabilize to after a natural infection or after a vaccination. The CD4 T cell response indicates a predominant polarization to a Th1 type, and although the role of the Th17 and Th2 cytokines is still matter of debate. Now, individuals with mild or asymptomatic disease are reported to exhibit robust memory T cell response months after COVID-19 infection. However, it is unknown whether the memory T cell, in absence of a detectable circulating antibody, can protect against SARS-CoV-2. Now the question still remains, can I get a reinfection? Well, if you look at previous time course of immune response to experimental corona infections in men, we see that IgG and IgA antibodies waned over first year after the viral nasal discharge, suggesting the protection against repeated infections with common cold coronavirus lasts only for 1 to 2 years. However, strain-specific immunity to clinical corona disease is preserved despite rapid waning of the antibodies. This is evidenced by the fact that none of the patients who had a prior infection developed any form of severe disease after reinfection. Regarding SARS-CoV-2, it is quite early, but early experiments in rhesus monkeys have shown that there is almost very little chance of reinfection. Now, after millions of infections globally, we have only anecdotal case reports of reinfection, mostly in patients who had a prior mild illness. Although the complete immune profile of these individuals is not clear, reinfection with SARS-CoV-2 suggests that the natural human immune response may not provide sterilizing immunity, but it definitely shortens the viral shedding, reduces the spread, and prevents severe illness. Now, herd immunity, is it going to protect us? Seroprevalence data has shown that nearly 10 times more SARS-CoV-2 infections are there than the number that are reported. This is based on the antibodies to the spike protein analysis. However, relying on population-based natural immunity, especially for populations who are at very high risk, is not really wise. Boosting the specific neutralizing antibodies and Th1 immunity to high levels with an effective vaccine, regardless of the prior immune status, may further protect these individuals. So to summarize, the initial immune response is robust in most of the cases. Both humoral and cytotoxic immunity is well produced. Reinfection is extremely unlikely. Even if it is, it really won't be a very severe infection. Vaccines are needed to control the spread. And lastly, SARS-CoV-2 may well follow the path of previous coronaviruses and become endemic in population as another common cold virus in the near future. Thank you for your patience and check our website for further information.